Welcome to the Talking HealthTech podcast. My name is Peter Birch. Today on the show, we're joined by Dr. Raymond Wen, Chief Growth Officer, Medical Director for Primary Care Services at Telecare Australia. G'day, Raymond. How you going?
I'm good, thanks, Pete. Thanks for inviting me on the show.
It's great to have you here on the podcast. Been keen to catch up with Telecare for a bit because I've seen, you've had a bit of news and excitement and traction throughout the year and prior to then too. And, always see you and the team out and about at all the industry happenings. But for those unfamiliar with yourself, tell us a bit more about you and your background and the work you do, and we'll go from there.
Sure. Well, I'm a GP by background. I'm still practicing clinically. I've always loved anything to do with systems thinking. So I was one of the co-founders of Telecare, part-time at the start and more full-time now. At Telecare, my role really is like any other startup, doing everything. My title being Chief Growth Officer, I am mostly in charge of business development, engagement, models of care co-design for new lines of business, and as the medical director of primary care services, looking after our kind of nascent GP arm as well. But prior to kind of Telecare, I was involved in the College of General Practitioners, in a few different working groups and committees. I've done work with Safer Care Victoria, Victorian Virtual ED Pediatric Advisory Committee. I was the GP co-chair of the GP Expert Advisory Group at my local primary health network and on its clinical council. So, look, to be honest, I just wear too many hats, and I've been trying to pare it back a little bit more recently.
Yeah. What is it? Try and do fewer things but better. That's been my mantra for this year. I don't know whether I've succeeded at that, but yeah, I can empathize 100%. But what it has given you is a great insight and view into the challenges facing primary care, but also for patients and consumers accessing quality care, I'm going to imagine. So tell us a bit about Telecare and the problem it solves, and we can start there.
Yeah, so Telecare, for those listeners who don't know who we are Australia's largest non-GP specialist virtual care company. When I say virtual care, just essentially telemedicine, but we do some remote reporting, and we do develop our own technology as well. So we've got over 300 specialists providing probably reaching about 4,000 consultations per month, but more importantly, partnering with more than 40 public hospitals and their facilities across Australia. So we have two streams. We do virtual services. So we provide virtual outpatient care, virtual inpatient care, remote reporting, as I mentioned, and some kind of novel models that we often co-design together with our health service partners. And then on the other side, we started building technology to solve our own problems. And so we started building products that other people wanted to buy. So we built Australia's first standalone and cloud-friendly and mobile-native eScript solution, which is integrated within Health Direct's GP Helpline, and hopefully with more in New South Wales as well, as we've passed their PSAF and single sign-on kind of assessments.
Oh, very cool. Yeah.
Short summary.
No, 100%. And we'll get to that element a bit, because that's interesting in itself. But if I just come back to this point around accessing good like telehealth consultations for the general public, when I think of the impact that telehealth services can have in Australia, my mind immediately goes to the vast geographical nature of the country and the opportunity to enable more people in, say, rural communities. That makes logical sense, and I know we're pretty good at it in Australia, but there's what's your kind of take on maybe how that landscape's evolved over the time? And because it's a lot more than just enabling a phone call or a video call. There's a little bit more to it.
Yeah, absolutely. So I think providing quality telehealth care is actually harder sometimes than providing quality in-person care, because the mistakes administrative mistakes over distance compound, because you can't tell checking with Mrs. Smith for her Medicare card details, for example. So I think Australia is a pioneer already in telehealth. Back in the days, we started off with Royal Flying Doctors and radios in terms of telehealth care. And so it really is a natural extension of that kind of history, given our vast distances, as you mentioned. Having said that, I think there was a bit of resistance when we first started to telemedicine, in that there was this impression that it was inferior to face-to-face care. Now, through COVID, of course, we started 6 months before the COVID pandemic, as I like to say, before telehealth became cool. Um, there was a bit of education about how it could be safe and delivered effectively. Now, of course, it isn't for every clinical scenario, of course, but for the 30 to 50% of clinical scenarios where telehealth essentially can offer the same level of quality, you're increasing the access to the portion of population that would otherwise have missed out on. And so you're actually improving the overall system-wide level of care that's accessible to the rural population, because otherwise they would have gone without and had no access to care at all.
Mm-hmm. And when you talk about the types of care that very much suit telehealth, and specifically for the Telecare platform, like what's well within the wheelhouse of things you do through the Telecare portfolio?
Yeah, so we started out in the virtual outpatient space. Initially, we were just a virtual specialist clinic, and then we took on one of the major contracts from Queensland Health, which was passed on to us by a big company, Telstra Health. And so we started there in terms of our public services. So physician specialties are really quite good in terms of telehealth, because a lot of the problems can be solved, particularly for review patients, through regular blood test monitoring and sometimes imaging. And clinical examination can in part be alleviated by the fact that some of our outpatient clinics are facilitated at the hospital by the junior doctors or by nursing staff. And when we first started, by GPs, when there was a Medicare rebate for the GPs to offer that service. Then we started moving into actually virtual inpatient care, which I initially thought, wow, this is really risky. But a health service came to us with a problem, and they said, you've got a panel of physicians. We've got a problem where we don't have enough GP VMOs locally at our small rural health service. Can we co-design something together? And through kind of a University of Melbourne evaluation, through a pilot period, we demonstrated that it was safe. And actually, you could run a hospital virtually with on-the-ground nursing staff and virtual kind of consultant physicians who are often, your quaternary center clinicians who are very comfortable handling a lot of complexity and a bit of uncertainty as well. Of course, you have to pick your patients. You can't do everything. And then we launched interesting things like virtual anesthetics pre-admission clinics, which again was a co-design process where the anaesthetist on the ground at one of our partner hospitals said, we're snowed under. We've got so many patients. We're not able to kind of get onto the anesthetic assessment clinic in a timely manner. And so patients' surgeries weren't necessarily being done on time. And so we co-designed a model where for the appropriate patients, the local anaesthetist would stream that to the virtual clinic, and we would have a virtual pharmacist as well as a virtual anaesthetist do the pre-anesthetic checks. And so there's actually a lot you can do. And of course, the big one, mental health. I mean, that was kind of pretty self-explanatory already, so I didn't touch on that. But we do run, we are the psychiatry partner for the National Telepsychiatry service that feeds into the Medicare mental health centres to back up the MMHCs.
Hey, Raymond, I want to come back to the, you mentioned before there was this model of care that was being developed and initially thought too risky. And I think you were talking about co-designing on a solution to then identify that, we can mitigate these risks and deliver care appropriately, which sounds like it's almost like a comparable level of care, or potentially even a high level of care in certain cases. I feel like that's a useful reference point for a lot of people in healthcare, because we're pretty good at identifying things that are risky in healthcare and finding, I guess, opportunities not to do things. So would you say that the real benefit in the reason that was enabled was due to that co-design approach, like doing everything transparently and openly together and finding that evidence and then resolving? Like, what was the secret there?
I think the secret is, having those honest conversations of what your scope can be, identifying kind of what you can pilot safely together. There was a lot of stakeholder engagement, so you need both the executives at the hospital willing to kind of take that chance. You need the on the ground nursing staff willing to work with you and understanding what you're trying to achieve. It's beyond just commercial kind of models of care, or I mean commercial gain. It really is about building for the community. The hospital partner we were working with was going to have to move the wards, essentially a collection of 3 small rurals, into a subacute type ward setting because they just didn't have the local GP VMO workforce to staff those wards safely. And so ultimately, 3 small rural communities were going to miss out on medical care. And so you have to look at the flip side of risk is, yes, there's risk to new models, but there's also risk to sticking with what you've got. And so I think the status quo that was going to be there is also a key factor in the co-design, where there was a lot of engagement and everyone was invested in finding a solution that was going to work. And so I think that was key.
And then I want to come to this point around building your own technology and then how that's kind of scattered. Because obviously you've got this pool of a number of capable clinicians to be able to deliver care. And in order to enable that care virtually or remotely, by definition, you got to leverage technology. I know of telehealth companies that will utilize solutions off the shelf and perhaps try and tie things together. So how much do you kind of build internally versus then pulling from what's available in market, and what's the reason for that approach?
So we probably built the majority of what we use. The reason is when we first started, as I like to say, telehealth wasn't cool. It was 6 months before COVID pandemic. And so we were literally dealing with PDF forms of DB4 kind of Medicare claim forms that had to be entered manually. And some of the health services that we work with were running on Excel sheets for kind of coordinating virtual care. So there wasn't much in the way of solutions out there in 2019, 2020. And so we had to build most of it ourselves. And so we also ran into the issue where some of the more, I guess, mind-numbing kind of aspects of running a health service, like data entry of Medicare numbers, provider numbers, date of birth, and the patient name. As a private company, our admin staff were quitting because it was just mind-numbing for jobs. So we just had to build like automated fax readers to be able to pull that kind of data out automatically. At least maybe like it was 80% accurate, but it meant that a human could spend essentially 90% less time just fixing, a character here, a character there, and then just pushing it through. So that's why we built our own tech initially for survival purposes, because we just couldn't survive and be an ongoing business. And then we started building more for the clinicians, which is the electronic prescribing tool, RxPad, that is now integrated into Health Direct's GP helpline. But we built that for our own, I guess, in some ways for our own survival as well. But we had a little bit more technology expertise by that stage. And so we integrated the clinicians' kind of user feedback pretty rapidly, myself included, and then built out a solution that was really useful for specialists in particular who often moved between clinics and needed one solution on their phone that they could access on any computer, on their phone, or on their iPad. And it was kind of a cloud-based and mobile native app that followed that workflow really well. And so these were the kind of specific sorts of problems that you solve as a health service, solving your own problems. But actually, because we were a health service and we ran our own service, everyone else also had the same problems. It's just that nobody else has built it or had the time or energy or the need or the necessity as a private company that might die otherwise without it to kind of build these solutions.
Interesting. It's on one hand, I can think how, there's a company might take the approach of, we're a clinical company and we're going to, we're a medical company. We're not going to be a technology company. and we'll rely on the experts to do that. But the other approach is, well, we know what we need and we know what to build, and our primary business model isn't to build technology to sell it. I guess it would allow you to really create bespoke workflows and niche solutions that are really optimized for your business. And it's still a smart business decision, just because it's not a scalable kind of SaaS product. It's in the end, meaning if you've got better staff retention and you can grow the business, and that's a good investment.
Yeah, it's what we call service enablement in most of what we build. So we built a light EMR for our inpatient service, because the virtual inpatient service was interacting with hospitals basically all on paper. And so you had to build a digital portal medium that could work into that paper-based workflow. So, when you were covering that hospital, you could see all the notes and they could see all your notes. But yet at the same time, it can all be printable and put back into the medical records so that it could continue the workflow of the routine kind of day-to-day care that happens when we're not on, when it's the physical GPs covering. And there's other things like, as a private service, one of our main challenges was if patients didn't turn up, we didn't get paid. And so we built really sophisticated algorithms and engagement pathways to make sure that patients, A, turned up, and B, if we think they're not going to turn up, we're going to quickly swap someone else in that we think will turn up. And so our failure to attend rates, when we kind of built this service enablement software, which I kind of see as a healthcare CRM, it allows us to have vacancy rates of 2% or below, in terms of specialists having 98% of their time booked up. Now, traditionally in public systems, you would just overbook patients. You would overbook 10 to 20% in your kind of public outpatient. And then one day, some days everyone turns up, and then your registrars are smashed and seeing patients until 6:30 p.m. And you would never run an airline that way. You can't just boot out 20% of the, customers all the time. So we had to build our own systems so that we could increase our income. But it's actually really useful system-wide, Australia-wide, to ensure that you actually have efficient outpatient departments. Again, I take your point. It's very rare, and we came across that a lot with investors. Are you a tech company? Are you a service company? What do you mean you do both? And everyone says you get distracted, and I take that point. But actually, the fact that we can build really quickly in solving our problems means that we can build better and faster and cheaper.
Sounds pretty cool. And look, I mean, it opens up all these really unique competitive opportunities. I can see how the benefits are there. You mentioned conversations with investors. Pretty sure you're at the other end of that whole process now. And I saw Telecare was acquired by Teladoc. Is that right?
Yeah. Yes, that's right. Yes.
Yeah. Tell me a bit more about that. Like, what was the impact there? What changes there?
Oh, look, I think it's very exciting times. So personally, I'm really into tech, and I feel like we've got a lot of tech that I want other health services to adopt, because not because it's going to make money for us. It's more that I think the Australian health system needs to become more efficient. And so previously, I think without a big parent company, as a smaller company, when you're trying to sell products that are, a little bit more grand than the eScript solutions, you would run into the, I guess, the skepticism about smaller companies, whether you would continue operating, let's say, in 5 years' time. Are you going to run out of money? But now with multi-billion-dollar parent, I feel confident that I can go out there and say, hey, we've got all this backing. We're not going to go bankrupt, so to speak. And we can now kind of start investing in selling some of the solutions, which I think have solved our problems, but other health services haven't had a chance to solve yet. So it's exciting times from that point of view.
So good. No, that's really interesting. And so with that kind of framing, and with the, I guess the appetite for virtual care or telehealth still very much there. And I know there's CIOs, CTOs, and even clinic owners that are looking to leverage technology to either see more patients in broader remits, or to even just reduce the strain on their clinical teams. Where do you see the ball going in terms of telehealth and telecare and virtual health, like this whole world, and there's artificial intelligence that's kind of overseeing everything as well. What's your kind of take on the future?
I think the future is that we can leverage telehealth a lot more to provide access, whether it's through telecare or not telecare. Like, I think public systems should kind of look at their own strategies and see where you can implement essentially a remote workforce. One, you've got really key benefits for society where patients aren't traveling, you're not having work downtime, you're not having carbon kind of emissions from driving a few hundred Ks or flying a few hundred Ks. And so you're also able to kind of mop up some of the clinician workforce that we see all the time, mothers, PhD candidates, fellows actually, from overseas. We've got like special avant kind of coverage for clinicians who are overseas. And then in terms of AI, I think my personal view is that AI is powerful and I think we should go for it, but we're too hung up on kind of this new exciting frontier where actually there is a lot of boring stuff that we already know works. And we should focus on getting that right first before we kind of talk about, how am I going to use AI to solve problems? Our CTO internally at Telecare has this concept that there will be a healthcare automation engine in our back end eventually. But actually, AI is just a tool that plugs into that. It's not like, because a lot of stuff can be algorithmic. It can be pathways that like the boring stuff. Like, you just need to know what you're programming into it.
Yeah.
And then you can automate it.
I think a lot of that, it's so true. Even if I look at some more kind of business operations stuff within Talking HealthTech, and I think, I wonder what we can leverage AI to optimize the, back-end admin or something. And then as I'm going through, I'm like, this is just like general process automation. There's not actually too much agentic, generative kind of thing. But I guess that was inspiring to kind of start with that and realize it's just getting a lot of the fundamentals right. And I think a lot of organizations can, if it inspires or interests them to, get some of those to dive into it and get the process and work on the business a bit more. I think that can be beneficial for everyone. But the right tools for the right time. I can see that work. Don't
get me wrong, AI is exciting. I one day I want to build medical AI that's used on Mars or something for astronauts. But
that's in the 10-year plan. No, nice one. Well, Raymond, I've appreciated the time to just get to learn a little bit more about Telecare and the work you're doing and the opportunity that exists for a lot of people, and even just a few ideas in how they can utilize some of these new models of care in what they do on a day-to-day right now. And so all the details will be in the show notes of this episode for people to check out and learn more and get in touch. Raymond, thank you so much for your time.
Thanks, Pete. Thanks for your time too.
We hope you enjoyed this episode of Talking Health Tech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.